thanks. Good morning, everybody. We're going into afternoon. So I want to thank ASAP and particularly Patricia Schubb, and I made sure I was here today, and I have tried to come to every meeting. This is such an important meeting, and ASAP, I think of all the societies out there, is really one of the most important. And you're all really fortunate because you have leaders from around the country here who've dedicated their practices and their lives to treating Chiari. And so you have this intimate setting. So I would tell and urge all of you to use it and ask everyone questions and use your time wisely to have this unique opportunity. So, my talk is about conservative management. And this really isn't a, operate or not operate. It really is not that simple. But it's also, I really want to focus on patient selection, because I think when you're talking about Chiari, that's one of the most important things. This is, when you're talking about things like cancer, it's pretty clear. You have to remove the cancer. There's other adjuvant treatments. But with Chiari, it's critically important to understand who needs surgery and who doesn't. And that's really what I'm going to focus on. And as a true story of how I became a Chiari a surgeon, which I think there's a lesson in it. I was all of, I think, 6 weeks into my attendinghood about 15 years ago, and one of my colleagues, who was just a couple years older than me, kind of patted me on the back in the hallway in clinic and said, "Hey, you like doing Chiaris?" I'm like, "Yeah." I kind of, real quick, he said, "Well, you're the Chiari guy," and walked away. And I didn't really understood what that meant. And as a resident, I was always fascinated by the outcomes. I would see some patients that just didn't do well, and it was very frustrating for the surgeon. And I can tell you, anybody that's doing Chiari surgery, we want to help patients. And we're hoping as surgeons that what we do, that we're fixing something, that the end result is going to help the patient. But it doesn't always turn out that way. So what I did was I started my practice really focusing on patient selection. I mean, to extremes, and I've learned a lot over the years. And one of the main things is separating symptomatic and non-symptomatic. Many people, as you heard from the last two talks, have Chiaris. But for many people, and up to 30%, they're completely asymptomatic. So that's just an anatomical variation on your MRI. I can tell you in the blood vessels in the brain, if you open up a textbook and you see what's called the circle of Willis, only 40% of patients have a textbook picture. Some people don't have one artery, some smaller than the other, some are duplicated. It's the same thing with the brain. So we really have to focus on symptomatic Chiaris. And with that, understanding those symptoms, do they relate and correlate to the Chiari? So the trick really is who to offer surgery to and who to follow. And it doesn't mean who to say, forget it, I'm not going to take care of you, but who to follow and follow those symptoms and see if they fall into that, into the side of the surgical arm. And really what that comes down to is patient selection. It's all about patient selection. And the only way you figure that out is by taking time to examine the patient, to listen to the patient, and to kind of to stay unbiased, which is hard to do. But as all of you in this room know, most of the symptoms of Chiari are debilitating. Now, some people have other types of symptoms that correlate with Chiari symptoms, but they don't have a symptomatic Chiari. There are other things. And the worst trap as surgeons we can fall into is then operating on those patients. And it's easier to do than you think. So let's go back, and you had a great talk this morning by Dr. Lovin. There's three different aspects of Chiari that are one. One is hydrocephalus, which is the fluid accumulation of cerebrospinal fluid in the ventricles, obstruction at the foramen of Monro, and you've heard that term and you'll continue to hear it over and over and over again, and then Syringomyelia. And these are all related. These aren't isolated events when we're talking about Chiari. Hydrocephalus in of itself can cause a Chiari by increasing pressure in the anterior fossa, pushing down and then causing this tissue to herniate. Once you have a herniation of tissue, what you have is a blockage of flow. And this is, in my practice, in my mind, is one of the most critical things. Is there an obstruction there? And you can't just look at it on a static MRI. So when you have obstruction of flow here, there's no flow of cerebrospinal fluid from the spine and the brain. And what ends up happening is you develop a pressure. You have two pressure components, one in the head and one in the spine. What happens in the head? When you cough, you laugh, you sneeze, you get all this pressure because there's an engorgement. There's no equilibrium of that fluid. What happens in the spine? That fluid also becomes built up, And the fluid, instead of circulating around, goes in, and you get that water content in the cerebrospinal, in the spinal cord itself, and it goes into a very thin a cavity called the central canal, and that starts to build up. That's why you'll see the syrinxes get better once you relieve this pressure. And one of the studies that we get, that I use almost exclusively on my patients, is a flow study. And you can see this here. See that flow pumping up and down? You can see that the white is the cerebrospinal fluid. See it squirting back up? This patient, although has a little bit of a Chiari, or low-lying cerebellar tonsils, there's wonderful flow going back and forth. I'm not going to help that patient at all by doing this. And I learned before, a true story about almost 10 years ago, I gave a lecture with kind of a bloody picture, and someone actually did get sick in the audience, so I use black and white now. So this is the exact same thing that you saw before. Here's the cerebellar tonsils that are hanging down. Here's the spinal cord, brainstem underneath, fourth ventral. So this is, if there's not that obstruction of fluid, we can do a beautiful surgery, but it's not doing anything because the fluid is already flowing. So the goal of the surgery is to unobstruct the obstructions. So I'm going to gloss over because you've got some great lectures today on symptoms. Pain is one of the biggest ones. The thing that usually brings patients to the doctor is pain, whether it's a headache, whether it's pain in the shoulders and the neck. Usually the other things are things we pick up. Oh, by the way, yeah, I've been dropping keys, and I notice I can't I hold my coffee cup, but I dropped it a couple times. I think I'm just getting clumsy. That's kind of secondary, and you see some laughs and smiles and nods in the head. It's the pain that brings patients to the doctor. And the pain, about 70% of patients with symptomatic Chiari will experience pain. The great majority is headache, neck, shoulder girdle, arm, and can also rarely have leg pain. It's usually a far more advanced form of it. But headache is the big one. And if you can ask any emergency room physician in this country, or primary care doctor, headache is almost universal. So you really have to kind of sift those out. And as you just saw from Dr. Iskander, that data showed, traditionally we talk always about that occipital pressure. There's not a small proportion that can be frontal and can be confused with sinuses and ocular migraines and other things. So it's very important to sift those out. The big one, the one that we get excited about as surgeons, is weakness. Once weakness manifests itself, and it usually starts in the hands and the fine motor, and that's why the first question I'll ask my patients is, are you having problems? And you have to give specifics, holding your phone for a long period of time, using keys to get into doors, doing fine motor movement, using the computer. You find you're dropping things more and more. And always ask, are they right-handed or left-handed? Because if you're right-handed and it's the left hand that's getting weak first, they're not going to notice it as much. But the weakness is something that usually shows that the disease is progressing. Numbness, almost just as common. Loss of temperature sensation, up to 40%. Very common with the syrinx. And I'm going to talk a little bit about that. But the syrinx basically separates the fibers in the upper cervical cord, and you'll see patients who will get burns because they lose sensation. It's not just a numbness and tingling, they'll actually lose sensation, so they'll burn their fingers on the stove, they'll burn their fingers on hot things because they don't feel it, and then they see these blisters on their fingers, which is another telltale sign. Being unsteady, bumping into things. For a long time, patients will think, I'm just getting clumsy, I've always been clumsy as a child, so deciphering that. Double vision, seeing two, kind of not necessarily a blurry, but kind of having shaky vision or double vision. Difficulty swallowing is a big one. I think it's probably a little bit higher than 8%. I think a lot of doctors don't really spend time to kind of talk about that or ask about that, but difficulty swallowing can be very, very subtle. And then tinnitus or ringing in the ears. And it's important to differentiate. These are all symptoms. Okay? These are things that you as a patient feel. Dizziness, fainting, face numbness, hiccups, sweating, things like that. But signs are things we're as doctors looking for. Signs are clinical things when we sit you up on the table and do an exam. One of them is nystagmus. So the reason we ask you to follow our fingers, not just because it's something that we learned in medical school, and we're doing it because we're looking for your eye movements. And are they moving together symmetrically, up and down, sideways? Do you see this kind of staccato movement like this and then back and forth. That's called nystagmus. There's lots of different things that can cause it, but again, it can correlate with the overall picture. Difficulty with gait, walking up and down the hall, and particularly when you're walking, good, I'm not connected to anything, I don't want to do a face plan here, going back and forth like this, and a quick turn. That's usually where the back part of the brain, the cerebellum, gives you the position sense of where you are. And so somebody who has compression of the cerebellum and the upper brainstem are going to have difficulty negotiating because your body's going to turn, but your brain, your visual system, there's a lag. And while that's trying to catch up, you're still back here, but your brain's over here. And that's where you get that unsteadiness, or what we call difficulty gait. Clumsiness, frequent falls, bumping into walls, hand atrophy. We'll look at your hands, the muscles in your hands. It can be very subtle and it's symmetric. Putting both hands out, you can't tell unless you put two hands to see if one's weaker than the other, particularly between the thumb and the forefinger. Weaknesses. The first thing I'll look for is hand grip. And what you'll see is patients who have symmetrically weak hands, when they're squeezing your hand, they'll start using their shoulders because they're trying to squeeze, but the strength's not there. So it's just a normal reflex to start bringing your shoulders up to try to compensate for that. That's another telltale sign. And then sensory loss. And the traditional is cape-like, and that's just the way the upper cervical spine, those fibers are formed. But the sensory loss can really be anywhere, and particularly in the hands. And then fasciculations, where we see kind of an upper motor neuron where you see the muscles kind of twitching. And this can be confused with early neuromuscular disease like ALS and other diseases. Again, important to put everything together. So almost all patients, by the time they get to you, particularly because most of them, as we said, come with what? Pain. Pain is one of the most debilitating things that can happen to the human body. And it's not just, it's in your head or deal with it. It causes fatigue. It causes depression almost universally. Memory loss. The stress from pain, and it's very, very well documented and studied, causes a whole host and cascade of events in the human body, all negative, and particularly psychologically. So again, these things aren't necessarily related to Chiari. They're related to the symptoms of the disease, which are all the things that we just talked about, but it doesn't necessarily mean that Chiari is causing these things. Again, they're a result, but they're real, but they're a result of the constellation of the signs and symptoms. And then what makes it worse is misdiagnosis, miscommunication. I see every head in this room right now going like this, because you feel these things and they're real, and you're going to 9 different people telling you 9 different things, from an extreme of you need 4 surgeries and I need to put metal in your neck and then you're going to have to come back and I'm putting, to it's in your head and it's just, I've heard everything from, you're a woman in middle age and this is common, to, things that it's like throwing gas on fire. So that makes everything even worse. What's important is education and understanding to reduce and relieve that. And it's amazing to me how many patients I see in my practice that don't need surgery, and they get better when you follow them along. Just sheer education alone of understanding, look, you're not going to wake up paralyzed. This isn't cancer, but your symptoms are real, and we need to get you to somebody who can treat these symptoms. Whether it's a migraine, or I've had patients who've had early ALS, things like that, that aren't Chiari. And again, the devil's in the details, as we say. So vetting out headaches. Okay, I have headaches and I have a Chiari and my MRI. You're not getting booked for surgery. You shouldn't be booked for surgery because you have to find out where the headaches are. Are the headaches related? So migraines, there's over 100 different subtypes of migraines, which I learned from our headache center, which I had no idea of, and I actually made her start to name them for me because I didn't believe her, and she started naming them all. And some of you may have even seen, there was a media recently of a woman in Miami, a reporter, who was on the scene live, and she looked like she was having a stroke. Her face drooped. She started going like this. She had a complex migraine. And everybody, the news, oh, look at stroke, and it was a complex migraine. That after they realized. Migraines can present in many, many different ways, but there's key questions you have to ask to differentiate. Pain is extremely common, but almost universally fits a pattern. It's not, I'm just hurt where? My hair hurts, my fingernails hurt, everything hurts. That's not Chiari. Chiari has, for the most part, a very specific pattern. And again, there's a gray area. There's always variability. Weakness is specific as well. It's not a the generalized weakness comes from just being tired and, beat up over all the other symptoms. But the weakness we're looking for is a very, very specific weakness, hand intrinsic, upper extremities. It, for the most part, fits a pattern. And if the symptoms don't correlate and you get overly excited about an MRI, I can tell you, and again, I think every doctor up here is going to give you their experience. So there's no, there's data and then there's experience. In my experience, if those symptoms don't correlate, regardless of what that MRI looks like, patients don't do well. And there's nothing worse than having a patient come back in your office after you've done surgery and their symptoms aren't better. That's the absolute, for any surgeon, is the absolute worst. What we live for is them coming back and saying, you've helped, either cured or dramatically helped my symptoms. So that's something that is critically important. And the other thing that I've learned over the years is if the first surgery doesn't help, then the second and the third and the fourth and the 10th is not really going to do anything. With a fair degree of certainty. Almost every patient that has a Chiari decompression is going to get some serious sense of relief immediately thereafter. So when it's kind of, well, now it's this, and now it's this, and now it's this, you have to be very careful. It's going down a very different path. Do repeat surgeries occur and need to occur? Yes. But for the most part, for the great majority, if the first surgery doesn't help at all at any point, it's a wrong diagnosis. So again, some more personal facts and thoughts about conservative management. 30%, which I would say more, of Chiari patients are asymptomatic, because that 30% are patients that we know have a Chiari, right? They came to light for something and got an MRI. There are, I would say, hundreds of thousands, if not millions, of people walking out there that have low-lying cerebellar tonsils, some form of Chiari, that are going to live their entire lives and never know that they have one. So I think that number is a little bit higher. No one dies of Chiari. So there's an asterisk on that. And when I say no one dies of Chiari, a patient that has Chiari symptoms and is diagnosed and is being followed, you're not going to wake up in the morning paralyzed. You're not going to just fall over and keel over and die. And I want to also add the caveat, I'm referring to an adult population. My pediatric days are over. We got great guys like Jerry and the rest of the people here. But people can die from Chiari surgery, or worse, or end up paralyzed and end up with chronic infections and end up, so you have to keep that in mind. Surgery is not a trial. It's not like trying a medication, right? You've got allergies and you go to your primary care doctor, well, let's try this, it doesn't work, okay, we'll switch it. Surgery, there's no return. Once that incision is made, once that surgery is performed, there's no going back. It's not a trial. Let's see how you do. If the surgery doesn't work, then we know it's not Chiari. That's not the right line of thought. Choose a treatment for the condition, not the symptom, right? So the treatment for somebody that comes in with an MRI with a pretty significant Chiari but clearly has migraine, the treatment is treating the migraines, not doing the surgery to fix an MRI. You start with that. Now, if the migraines, or if they're not truly migraines, those things have to be teased out. So you're treating, again, the condition, not the symptom. And the degree, this is the biggest one, I think another take home from the conservative management, the degree of herniation really has limited prognostic value. You have to have that clinical correlation. And I'll give you an example of real patients. This is somebody who has a pretty significant Chiari and basically came in with migraines for years, has a family history of migraines, classic migraines, photophobia, noise, 100%. She just wasn't treated appropriately, and she was booked for surgery somewhere else, and I sent her to a headache center, and her migraines were treated because she got the proper treatment. She has absolutely no symptoms whatsoever. I've been following her for a very long time. Now, and you can see here, you can see the CSF there. So yes, she has this herniation here, but she has some CSF flow. Now let's do the opposite, where here's somebody who is very symptomatic with not a huge degree of herniation, but there's CSF obstruction there. And you saw that flow. We have imaging now that shows that beautifully. So even though this wasn't as dramatic, her symptoms were. This is somebody who was losing hand intrinsic strength, who basically was having difficulty with ataxia, was blowing it off for a very long time. Oh, it's this, it's this, it's this. And, the symptoms correlated. So I'm going to talk a little bit about syringomyelia because I know people try to put these in different compartments. And yes, there are other forms of causes of syringomyelia, but we're going to talk about it in context of Chiari, which is the great majority of patients. 70% are associated with a Chiari malformation, the great majority. You have to rule things out like a cystic tumor, particularly if there isn't a Chiari involved. You always have to get an MRI with contrast to make sure there's no other pathology there. Trauma is a very common cause, and you have to, this becomes another issue of, okay, maybe there's low-lying cerebellar tonsils. Somebody was in a really severe motor vehicle accident, has a mid-thoracic syrinx. That syrinx, for the most part, is going to have a very low likelihood of recovering. We're not talking about a high cervical with a large Chiari because it's a different mechanism. Basilar invagination, which you're getting a talk from a world leader, and Dr. Menendez here later, so I'm going to hold off on that. And again, we all know in this room what a syrinx is. There's that fluid-filled cavity. We kind of went over a little bit before about the CSF obstruction and what causes it. And these are the MRI images. And you can see how large they can get, how they just split that spinal cord. So this is gray as normal spinal cord. You can just see it being completely dissected. And there's just little thin rims of spinal cord that have been split. Now this hasn't been severed. They've just been split and pushed out and stretched. And that's where the symptoms come from. And when the decompression occurs in the cerebrospinal fluid, now the pressure on the outside is less than the pressure on the inside. The CSF seeps back out into the normal flow pattern. That's where we see this slowly resolve over time. Symptoms, again, same pain, sensory loss, which is what we call a dissociation between loss of pain and temperature and touch. That's where you get this burning sensations. That's where, when I see a patient, even before I see the MRI, you'll see that this kind of, usually in the neck and the back and the arms, if it's in the thoracic spine, lower, you see this kind of band-like distribution, and it's a very, very distinct burning type of pain that really nothing helps. It's a horrible, horrible type of pain. Weakness, particularly in the arm and hand. And so let me kind of start to get into conclusion here of some advice. And this goes for anything in healthcare, you are your only proponent. There's no one else that's going to be a proponent other than you, and you have to ask questions. There's definitely a generation gap here where, even my own parents who are like afraid to ask doctors questions. Oh, he's so nice, I don't want. Like, you're there, that's their job, ask them a question. If they're not giving you the answer, then move on. So you have to be your proponent. And that doesn't mean that your doctors aren't partners with you in this, but it means you're the only one that knows your symptoms. You're the one who is responsible for you. So, don't be afraid to speak up. Make your doctor explain everything to you. If you don't understand it, keep asking. Make them show you on models. Make them go over things. Ask them to talk to other patients. Support groups are huge. I would urge any of you that if you've never been to one, go to one. If you don't have one in your area, start one. It's very, very helpful. Get a second opinion. Getting a second opinion is not a problem. If a doctor gets offended because you're getting a second opinion, that's a telltale right there. That's a telltale right there. And I can speak for all my colleagues in this room, we're usually going to offer you and tell you to get a second opinion because that's a good thing, because then it gives you confidence that, yes, there's there. And I don't have a problem if somebody has a different opinion, because sometimes, there's a gray area. And they may have picked up something that I missed, and we can say, oh, they didn't tell me that. Okay, that's not a bad thing. When you start getting into third and fourth and fifth, and that starts to become a problem, because now what tends to happen is you get more confused than you were in the beginning, because now you have experts and 5 different experts telling you 5 different things. So I would keep it to 2 total to 3. The internet's not a bad thing. I know there's this idea out there, oh, doctors hate that. I love it when patients come in and they have a list and they've been on the internet, because now I can start to pare down. You have to take in context with what the source is, because especially in Chiari, there's a lot of nonsense out there, because you can get individual people who have different experiences or bad experiences, or some that have, you have to just look at what the source is. And again, ASAP's wonderful for that, because you have experts from around the country that meet together and talk together and have a comprehensive overview. But the internet's not a bad thing. It's a good thing. Use it. So how do I treat my patients? What is my treatment paradigm? where I go from conservative to offering people surgery. And again, this is my personal one. There's no right or wrong for a great majority in that gray. Sometimes there's right and wrong, but we're talking about the gray here. I look at a patient with symptoms first, MRI second. I teach residents and fellows, you deal with the symptoms first, and you look at the patient and you see what the symptoms are, and then you correlate the MRI second. Patients who come and have early symptoms, mild symptoms, I follow them. Again, why? Because you're not going to wake up paralyzed. This is something that you have to follow closely clinically, not necessarily MRIs. Getting an MRI every 3 months really is not, you're not going to see that. The symptoms are going to occur before any changes on MRI in the great majority. So you follow those symptoms and you see. There's always some exceptions, but for the most part, that's served me well over the years in my patients. Again, that's something I say to my, because this idea of a lot of times someone will get a diagnosis of Chiari with all these symptoms, and a primary care doctor or neurologist will say, oh my God, you have a Chiari, and if this isn't taken care of, you're going to be in a wheelchair, and this needs to get done. So you have to kind of put things in context and explain to the patient what a Chiari is, what the natural history is. It's an indolent process, meaning it's slow, and the symptoms continue. My biggest job is teasing out my patients who want to ignore it and pretend it's something else, and you have to kind of give them a dose of reality and say, look, you weren't dropping things a week or 6 months ago when I saw you, now you're doing it. You never had any problem swallowing, now your husband's telling me you're choking on food, so you have to really pay attention to the symptoms. No symptoms, no surgery. And again, you see asterisks after certain things. No symptoms, no surgery. Because if there's no symptoms, I'm not sure what I'm treating. I'm treating something that could happen, and that's this very slippery slope. Well, I'm okay with a patient that I trust and I know is going to follow up with me, having him come back to my office and together sitting down and saying, okay, are you symptomatic or not? So again, as long as we have good follow-up, no symptoms, no surgery. Any motor weakness in the hands that I see with a documented Chiari, my level goes way up. When we start getting into motor weakness, that's when we start getting into looking at irreversible things. That's when the time frame and surgery starts to become more on the forefront. So conclusions, the symptoms of Chiari are multifactorial, which you're going to hear all day today. MRI findings do not always correlate with clinical symptoms. You have to focus on the clinical symptoms. And when we talk about Chiari, we have to talk about symptomatic Chiari, not incidental Chiari. It's treatable. Right patient choice is essential. One of the first things I say to the patients is, this isn't cancer. This is a good thing. This is a treatable problem. You're having symptoms that are debilitating. Let's focus on getting those symptoms better and figuring out the best tool to do that. And with that, I will finish, and any questions I'm happy to take. Yep.
I just have one question. Have you seen anything where the mental doctors are getting, I don't know how to, together?
Yeah, I think I know what you're saying. Basically that we get people who, neuropsychology, psychiatry together as a team approach. What a novel concept, huh? No, we do mental health horribly in this country, awful, from the largest institutions to community hospitals. And it's something that has been a pet peeve of mine. One of the things that we've instituted is we have, I think we're one of the few places where we brought psychiatry into, at the university, we kind of brought them in, they're part of us. So we have psychiatrists and 3 full-time neuropsychologists. The problem is it doesn't pay. And it's like, the question becomes who's going to pay for it. There's ways to do it the right way. But that's how you treat this disease. It's multifactorial. You have to dissect out. Surgery is the absolute last option, right? Surgery is what you come to after everything else has been ruled out. But no, we don't do it well. Back there, and then I'll come up to you.
Hi, I have a question for somebody that was not able to make it to the conference. The question was, post-op decompression, what happens when you have a concussion after that?
Wow. Well, as you know, concussion, especially as we know now, is it's severe trauma to the brain by definition. So you're adding 2 insults to a brain. So it really depends on the patient. It depends on, so it's not, from an anatomical standpoint, as you saw from the first lecture, unless you have some type of very focal pinpoint, it's certainly not going to help. And so you're going to have all the problems of the concussion compounded with whatever they're recovering from the decompression. No question?
Yes, I've never seen that syncope seems to to the Chiari, or would it be like an adequate patient that they have to go?
Yeah, so the syncope is this blacking out, and you see it much more in the pediatric population than you do in the adult, and the respiratory and all that is you see that a little bit more in the pediatric population. Yeah, and it's compression from the brainstem, because the brainstem is our life center. It's where our heart rate, breathing, an area of the brain called the locus coeruleus, that's what makes us awake and alert. So any compression of that can cause syncope or a really low heart rate.
Yeah, well, because my daughter has a syncope, and she's we went to a heart doctor and everything, and they said that she had no heart issues, but she does have the syncope, and I didn't know if they were...
With a Chiari.
Yeah, because she also has epilepsy. So I didn't know if it had something to do with her seizures, or if it was because she does...
So they did the exact right thing. The first thing you're looking at is cardiac. I mean, MRI, if there's a Chiari there, but are there any cardiac issues? The seizure part adds, that's something that really has to be vetted out, because seizures, as you know, can be drop attacks, can look just like syncope. And now that's where they do continuous EEG monitoring and things like that to rule out. I think of everything else, and I would defer to my, you have experts, national experts here in pediatrics. I think if you rule everything else out, it depends on the Chiari and everything else.
I'd like to move, thank you very much. We'd like to move on to our next speaker.
Okay. All right, guys.